Our first speaker for this session is Professor Stephen Nicholls. He's a professor of cardiology at Monash University. Many of us will know Professor Nicholls as the director of the newly opened Monash Heart Hospital, where he practices as a preventative cardiologist. Professor Nicholls leads a translational research program focusing on the role of metabolic risk factors in the mechanisms in cardiovascular disease. This includes lab-based research for the mechanisms of atherosclerosis, plaque imaging, and leadership of clinical trials for novel therapies. He has raised more than $160 million in research funding and has published more than 1,100 manuscripts, book chapters, and conference proceedings. Professor Nicholls opened and leads Australia's only dedicated heart hospital and is the president of the Cardiac Society of Australia and New Zealand. Please join me in welcoming Professor Stephen Nicholls.
Sorry, can you hear me? Sorry, that just came unstuck. Thank you for the kind introduction and invitation to spend a bit of time with you this afternoon. I normally have a disclosure slide. My disclosure slide probably should be, I have a problem in that I can't say no. And as you've heard a little bit, and you'll see a little bit, there's a little bit of megalomania that comes in terms of at least my journey and where it ended, where it's got to. I'm a cardiologist. I did not set out to be most of what you heard just a minute ago. I did my basic training in Adelaide. I did my cardiology training in Newcastle. During my basic physician training and my cardiology training, I presented a number of abstracts at national meetings, and that was really just using clinical data in the department because I thought it was interesting, and I thought that there were good clinical mentors who were very much supportive of me doing that, and then that led me on the start of a research career. And I started my PhD in Adelaide. My PhD supervisor moved to Sydney in the middle of that. But this kind of gives you a sense for where my PhD started. And it started at a time when statins started to be widely used. And on the basis of clinical trials that showed that statins were good, they actually awarded the Nobel Prize to Brown and Goldstein because they discovered the role of the LDL receptor in lipid metabolism. And they were invited to write an editorial in Science, and they said heart disease will be eradicated by the turn of the century. And then I decided that I would go from Newcastle back to Adelaide to do my PhD, and I was going to look at HDL biology, and I was going to look at the good form of cholesterol. And the head of my department took me aside at my farewell, and he said, "I'm not sure you've picked the right group to do your PhD. There's new future in lipids." And I can tell you that in 2023, next weekend I'll be at the European Society of Cardiology presenting a late-breaking clinical trial of a novel therapy that's just gone through phase 1. So there's lots of innovation, and it really has kind of played its way through my story. So my PhD was about HDL, and I was trying to make sense of the functional properties of that. We understood the anti-inflammatory properties and how that contributed to its role in cholesterol efflux function. I was able to demonstrate that HDL possessed anti-inflammatory properties in vivo, and that was independent of its effects on lipid transport. I've subsequently led a number of clinical trials using plaque imaging. We're able to infuse HDL into patients who'd had an acute coronary syndrome. We could show that we could, in a short period of time, start to shrink the plaques in their coronary arteries after their heart attacks. And then I'm part of the leadership of a 19,000 patient clinical trial that will report out at the end of, sometime early next year, which is actually looking at the effects of simply infusing HDL into patients after a heart attack and look to see whether it will reduce the chance that they'll have a recurrent event. So that kind of brings a nice tie from a translational perspective from starting with cells and rabbits and ending up with close to 20,000 people and potentially a new therapeutic that comes to the clinic. I went from Australia to the US, and I went to the Cleveland Clinic to do a postdoc, and that was to use plaque imaging. We've had this proliferation of imaging modalities in the last 30 years that allows us to look at atherosclerosis in a range of different ways, different vascular beds. We can see where the disease is. We can quantify how much plaque there is. We can start to see the individual components within the plaque. And what was really intriguing to us was, could we then use the same modality in the same segment of artery at different points in time to understand what were the factors that influence the natural history of progression of disease, and then take it one step further and actually then integrate serial imaging into clinical trials. And so we started doing that from an invasive perspective. I'm going to show you some invasive techniques at the start, and at the end of my comments I'm going to show you some non-invasive studies that we're doing today. But this involves using intravascular ultrasound in patients with coronary atherosclerosis, and using the highest doses of the two most potent statins, we could actually show that we could regress plaque, and that really became the gold standard for what we should be aiming to do for our patients from a secondary prevention perspective. Beyond simply looking at the size of plaque, we can now start to see the features within. I can measure the thickness of the fibrous cap, I can measure the amount of lipid, the amount of macrophages within the wall of the vessel. And this is data from a clinical trial that we reported the year before last, where we took patients who'd had an acute coronary syndrome and actually gave them a PCSK9 inhibitor, a potent cholesterol-lowering agent on top of a statin. And you could see by doing that over 12 months, we not only shrunk the plaques, but we stabilised the plaques. And that's going to become a really important feature in terms of how we try to keep patients out of hospital. The next kind of part of the story is about a factor called CETP, cholesterol ester transfer protein. Now, CETP plays a really important role in lipid metabolism. But importantly, what it really does is it blocks the transfer of cholesterol from HDL to LDL and VLDL. So essentially, it doesn't load the bad lipoproteins up with more cholesterol. And so in theory, if you inhibit CETP, you're going to raise HDL cholesterol levels. And we thought that would be a good thing from a therapeutic perspective. I have led multiple clinical trials in this space. And as you can see, this is a somewhat sobering kind of story, that clinical trials don't always work out the way you want them to. Despite all the biology, despite all the early kind of data, here are 4 large clinical trials. 1, the drug was toxic. 2, the drug didn't do anything at all. And 3, the last one was at best a modest benefit. And in fact, you need to be able to take the kind of the good with the bad. Now, sometimes it's a little bit unkind, and this was an industry kind of journal that came out after I presented another one of these failed studies to really just kind of highlight that sometimes drug development's hard, and it doesn't always work out the way you want to. Now, what we've used is we've used genetics to go back and try and understand where having less CETP would actually be protective. And using the UK Biobank and other really large cohorts, 500,000 people, we've been able to perform Mendelian randomisation studies. And what we've been able to do is essentially simulate clinical trials by doing that, because you can take all the people with the polymorphisms with less CETP and put them in one group, and all the people without those polymorphisms in another group. And if you do it in hundreds of thousands of people, they're actually going to balance out with regards to everything else: age, sex, diabetes, everything. So it essentially becomes nature's clinical trial. And what we find that by doing that is that polymorphisms associated with less factors that influence LDL metabolism actually are all protective, whether it's HMG-CoA reductase, which is the target for statins, whether it's PCSK9, and we have PCSK9 inhibitors today. Turns out that when you do that, having less CETP is a good thing. And so I would suggest that having less CETP is a good thing, but it's got nothing to do with raising HDL. It's all got to do with how much you lower LDL. So that allows us to rethink the whole CETP story, to develop new CETP inhibitors, which are actually really potent at lowering LDL. You can see that they can lower LDL cholesterol by 50%, and then to take them into now new clinical trials. So again, we've learned from the lessons of previous studies. We've used genetics to inform what we think the studies should be moving forward. That's helped us design the therapeutic that we think is probably more likely to work. Now we go and take 9,000 people in a clinical trial and answer the question, and this study is ongoing. And that last point is really important, that preclinical work's critical, early phase human research is critical, but ultimately what happens to our patients is ultimately the most important thing. And I wanted to share with you a few clinical trials that we've conducted when I came back to Australia, and at first was at SAMRI in Adelaide. leading the cardiovascular group there. This is a study of an anti-inflammatory agent called vorasplidib. We thought that would be a good thing. Turns out it's a really bad thing. It actually increased the risk that you'd have a heart attack. So that's not a drug that's going to come to clinical practice. We then thought we'd try what we call a BET inhibitor. This is essentially the first epigenetic approach to treating heart disease. Looked like maybe there were a few less events, but didn't actually hit a significant p-value. So that's not a therapeutic that will come to clinical practice. We've tried giving high doses of omega-3 fatty acids. Fish oils are interesting, and there's lots of fish oils on the counter at the pharmacy. And while they all say proven to improve heart health, I can guarantee you none of them are, right? And so they're tiny doses of omega-3 fatty acids that are useless. What we have learned is that how much omega-3 fatty acid you give is important. So rather than the couple of 100 milligrams that a capsule will cost in one of those big tubs at Chemist Warehouse, these are 4 grams a day, right? And it turns out that it's not only important how much you take, but it's important what you take, because on the left you see a clinical trial where the omega-3 fatty acid was all EPA, and that reduced clinical events. And on the right, you can see when it was a combination of 2 different omega-3 fatty acids, it didn't work. So it helps to define where that may go from a therapeutic. This is our latest clinical trial that we reported earlier this year. This used an agent called bempedoic acid. It's a lipid-lowering agent, but it doesn't cause the muscle aches and pains that statins cause. And I run lipid clinics. I see a lot of patients with statin intolerance who cannot simply take those drugs. And so this is a study of 14,000 patients, all with statin intolerance. And they either got that drug or placebo, and if they got the drug, it lowered LDL, and it lowered LDL, and it lowered their risk of cardiovascular events. So this is a therapeutic that's available in a number of countries. It's not available here yet, but it will change the way that we treat high-risk patients. Just to kind of tell you about some studies that we are doing, and you'll hear about some more of them with the next speaker. Horizon is the first clinical trial to actually use a therapy that will lower Lp(a). That's a really interesting risk factor. It's been an elusive risk factor. We don't know if lowering Lp(a) will actually lower risk. This will answer the question. This is a study of a dual incretin agent that Sophia and I are both working on in patients with cardiovascular disease and with type 2 diabetes. And so the idea will be that we'll not only improve in glycemic control, but weight loss and improvement in a range of other metabolic parameters, will that reduce cardiovascular events. And then what I wanted to share with you was the next chapter. So I've gone Adelaide, I've gone Sydney, I've gone Adelaide, I've gone Cleveland, I've gone Adelaide. Adelaide seems to come up a lot. And in 2018, there was one new chapter to that, and that was the opportunity to do something that had never been done before, and that was to build the country's first dedicated heart hospital. It would be located at Monash University on the campus. And that creates a whole series of challenges, because what we're going to do is we're going to take cardiology and cardiac surgery out of Monash Medical Centre, and we're going to move it 1.8 kilometres down the road across 2 very major roads, and you might as well put it 100.8 kilometres away, because while you're taking cardiology and cardiac surgery, you're not taking orthopaedic surgery, haematology, endocrinology, infectious diseases, neurology, you name it. So you need to not only build a building, but you need to build a complete new model of care, because you need to work out how you're going to work with all of those people. So I have essentially had to go back to medical school, because I now have to know everything about what's going to happen and how I'm going to deal with the neurologist, how I'm going to deal with the haematologist, what happens if an old lady falls out of bed and cracks a hip, how we're going to fix that, and actually completely rework the model for that. So we've built that, we've opened that early this year. That is full already, and shows you that cardiovascular disease has not been eradicated as much as Brown and Goldstein might have liked it to have been. By putting it on the university, we were given another directive, which was to, can you come up with some way of integrating the heart hospital across the whole university? We don't know what that is, but if you could come up with an idea, that would be great. And that was the idea for establishing an institute. And the idea that it would have a physical home in the building and an entire floor of research and teaching, within the heart hospital, but how do we actually make it live throughout the university, all of the faculties, all of the campuses, including the international campuses. We have 700 members of an institute of engineers, IT, vascular biologists, clinical trialists, you name it, and it's all about trying to do bigger things. And what we've tried to kind of coalesce those bigger things around grand challenges. And we've purposely done this because we think these are areas that are really important, but they will invoke a different response in everybody. So if I bring multidisciplinary collaborative groups together to do bigger things, they'll all kind of come and want to kind of build on an idea in a slightly different way. And that's been really exciting. Just to kind of share with you a few of the kind of new projects, and it's probably more of an implementation perspective that we're kind of working on at the moment. We know that there's a lot of interest in polygenic risk scores and their ability to predict risk of cardiovascular events, but can they actually triage patients to more intensive therapies? And so will people with higher and lower levels of polygenic risk respond to different therapies? And so we're doing a number of studies where we're looking at how we, one, integrate polygenic risk scores in primary care on the left, and on the right, we're looking at the effects of statins on plaque progression using CT, a non-invasive imaging modality, on plaque progression in people with higher and lower levels of polygenic risk. What if we simply show people their information? And one of our PhD students, a really talented nursing colleague of ours, is actually taking patients with type 2 diabetes and randomising them to 3 groups. 1, just giving them standard risk factor guidance. 2, doing that and showing them their imaging. Or 3, giving them advice and showing them their genetic risk score and seeing how that will influence their behaviour, how it will influence their risk factor control, and how it will influence plaque progression. We're trying to see if we can repurpose statins in other settings and how can we make it a cardio-oncology drug. We know that patients who are treated with immune checkpoint inhibitors for a range of cancers are at an increased cardiovascular risk. Can we take individuals with melanoma and can we randomise them to treatment with a statin or placebo to see if we can slow the accelerated progression? Because one of our concerns now is that there's such an advance in cancer therapeutics that more people are going to survive those diseases. And they're going to find themselves at a greater risk of having a heart attack or stroke. So how can we implement preventive strategies in the cardio-oncology setting? Can we look at new and emerging risk factors? And so clonal hematopoiesis becomes a really important factor that the field is looking at, how it ties into inflammation, and MRFF funding that allows us to identify individuals with CHIP mutations and then perform heart health checks and follow these people over time. And then what we're going to start to see is how we then integrate people with CHIP mutations and high cardiovascular risk into clinical trials. And we'll probably start those activities next year. So I was part of building a building in Adelaide with SAMRE. I showed you a building that we've built at Monash, and now this is another building we're about to start building. So across the road from the heart hospital, I'm going to build an innovation centre, and where it's going to sit in there, in the first instance, are research accelerators and commercialisation activities. And what we're going to do is we're going to put teams in that facility who are going to work with our clinicians and our researchers in the heart hospital to get them to think about how they innovate, how they accelerate, how do we take things beyond simply writing a paper, and how do we actually get it into the hands of people where those discoveries can make a difference. And you can see that there'll be a range of other activities that kind of go on there. The first thing that will sit in there is the National Research Accelerator that's dedicated to stroke and heart disease. This is MRFF funded. I'm the chief investigator of that at Monash. You can see that involves a range of other partners across the country and looks at stroke, looks at heart failure, and looks at vascular disease. The other thing that we've thought about is how do we position what we do, not just in terms of Victoria, not just in terms of Australia, but what do we look like in terms of the region? So a number of years ago, I established an academic group called the Asia Pacific Cardiometabolic Consortium. This was how we were going to do academic research projects together, educational activities together. You can see we've already got a number of countries across the region that are represented. It's really fascinating when you have a conversation and you talk about what's important from a cardiovascular disease perspective in Australia, South Korea and Pakistan. I can tell you that the issues that matter are slightly different. At the same time, there are a whole bunch of issues that we kind of share that are the same. And here is exactly the first big study that we're doing across that network. And what we're going to do is we're going to take patients who have had an acute coronary syndrome in 8 countries, and we're going to randomise them to standard of care versus extra goal counselling to see if we can influence LDL cholesterol control and whether there'll be differences in different countries in terms of the way we do that. And there'll be more activities that come with time. So my final 2 slides, my first slide told you that heart disease was going to be cured, and it's not. I've got a full heart hospital, I can promise you. The second thing I can tell you is that there's a lot of really exciting stuff going on in this field. This slide has a whole range of therapeutics that either work or we're going to know whether they work or not in the next few years. And one of the challenges for me as a clinician is how do I make that all make sense in the clinic? Because I can't give all of these to one patient. And where we're going to go in the next step is personalised prevention. Today, we do the same thing for everybody. Tomorrow, we will tailor the right therapy to the right patient, and we'll have the right biomarkers and the right therapies to help us do that. I think that's where a lot of the research will go. So that's going through a lot in a short period of time. My final slide is that you do not do this alone. This slide represents a small number of a lot of people, mentors, colleagues, people who have been extraordinarily influential in helping you zig and zag rather than go on a straight line, and that's exactly what my journey has been. People I have the opportunity to mentor, people without whom I wouldn't be able to do the work that I do today, an extraordinarily supportive family who have allowed me to go on this incredibly indulgent journey, and then finally the patients with whom none of this wouldn't have started, and it wouldn't continue to happen, because if it wasn't for them, we wouldn't ask the questions. And I thank you for your attention.
Thank you so much for that inspiring talk. I'm very sad to hear that cardiovascular disease still exists. We'll now open the floor to any questions.
Thanks for your talk, Professor Nicholls. This session is the art of communication and networking, and you've mentioned that you're from Adelaide, and I was just wondering if you could comment on the merger between UniSA and Adelaide Uni, and whether or not Melbourne and Monash would ever merge.
I think the merger between Adelaide and UniSA is long overdue. I think Adelaide is a city that would benefit from having 2 universities rather than 3. And I think that while there are a lot of reasons that are underlying that merger at the moment, I think it establishes ultimately a much more competitive, innovative university. And if I was the state government of South Australia, what I would be challenging now the 2 universities moving forward in that state is how do they think about the impact of what they're doing. So I think we focus at university levels a lot on how many grants we get and how many papers we publish, and that's great. My numbers all look really good for that, so my dean's happy. But does it actually go anywhere? And I think that's what we're going to be asking of our universities in years to come, and I think you're going to have a brand, bold, innovative kind of mega university in Adelaide that may give that opportunity. I think in this city, which is considerably larger, you have a great number of academic institutions. I don't see Melbourne and Monash merging, but perhaps collaborative relationships, particularly involving some of the other universities, I think there's great opportunity there. And we've thought a lot about that just in terms of how we set up the Heart Hospital and the Heart Institute. Was actually, they're very external facing entities so that we try to be inclusive.
Hi, Steve. Sorry, over here. I wanted to ask a question about how patients have responded to the new hospital, which is obviously potentially quite a big change for them as well as for all the people working there. How's that gone? Have you had to have particular conversations with them? Has it been welcomed?
Patients love it. I mean, our problem is that, when it's a brand new hospital, you worry that they're not going to go home. Because they're all single bed bedrooms. We're running what we call a universal bed model. So we don't have a surgical ward and a medical ward. We don't have a coronary care unit. The whole hospital is one big ward. And what that means is that we're not going to move the patients around. And if you have, in most hospitals, if you have a heart attack, you'll stay in hospital for 3 to 5 days and you'll probably occupy 3 to 5 beds. In this hospital, you occupy 1 bed and we actually take the care to the patient. So I think they've been very happy about that.
I don't mean to, ask more controversial questions, but I feel like I've had conversations with other students and some junior doctors and some doctors, and I feel like I haven't had a very clear answer to why the heart hospital is not connected to MMC and why it's separated. I think as I understand it, the answer that you gave was partly that it's more integrated with things like engineering and with the campus itself. But it's my sort of understanding from a lot of consultants and clinicians that siloing, different areas of health just leads to, worse health outcomes, not better. I'm just wondering what your thoughts are on, siloing cardiology out from the rest of the hospital itself.
No, it's a really important question. And so the first thing I'll say was the original concept of the heart hospital was not my idea, right? The original concept for the heart hospital was to build a building out the back of Monash Medical Centre. And then that concept evolved to one which was going to place a hospital on a university campus and drive the innovation that came with that. But, opportunities come with challenges. And I've heard every criticism of this project from inside and outside. And that's why we've had to focus the efforts we've had to establish the model of care. I disagree and would argue strongly. I'm happy for somebody to show me the data showing that it ends up in worse outcomes. There's no data to support that at all. I think that's just people who are unhappy they didn't get it, to be perfectly frank. But that also means that we need to, change everything that we do. And so we can't just move a department down the road and think that's all going to work. And that's been part of what we've done. We also know that there's a massive expectation that comes along with building a building like this. It needs to succeed. It needs to do a lot of things for a lot of patients. It needs to embed itself within a broader community. It needs to have centres of excellence from clinical care, and we have some of those already, and we will build more over time. It needs to embed research and teaching to deliver on the promises that it's kind of set out. And then it will need to attract the best and the brightest. Hopefully some of them are in this room, but some of them will be on the other side of the world. And that will be a journey that won't be fixed in the first 6 months. Our first priority has been this year to be safe for our staff and for our patients. I think we've done pretty well with that, but now we kind of grow forward.
Join me in one sorry.
Is there time? If there's no time, I won't ask my question.
I think we've got time for one more, yeah.
Okay, well, that was fantastic. And I love the way you showed that these trials, huge trials, show things don't work. It's such an important thing to do, and your vision. The issue that I wanted to raise was around the Chemist Warehouse, actually. Yeah. How do we change the public from going and buying omega-3? I have little kids with bad epilepsy who are on omega-3. It's doing nothing. What do we do about that, Steve?
So, and it's not, Australia's not the only country. The nutraceutical world is completely unregulated. And I'm not allowed to do anything with a pharmaceutical without it having jumped through 50 hoops. I'm not allowed to make any bold claims beyond simply what a drug showed in a clinical research project. And in fact, if I said a word beyond that, there'd be somebody in the room and I'd be in trouble somehow with the TGA for doing that. And yet the nutraceutical world and the alternative therapies world can just make whatever bold, outlandish claims they want. I think that we do need to have better checks and balances. It needs to start with government. I think the omega-3 fatty acid space is a really good example of that. I actually ask my patients, because they tell me they take fish oil, so I ask them at the next appointment to bring it in. And they bring these big tubs. And so occasionally when I am in a chemist and I'm waiting for my script to get filled, I will, and then this sounds a bit nerdy, I will go down the omega-3 kind of aisle and start picking all of the tubs off the shelf and actually seeing what it is that they've actually got. And I know that for any of my patients to take the actual amount that they would need to take for that to even potentially work would probably cost them $50 or $60 every 3 weeks. And Monash is in a pretty diverse community with a lot of people who can't afford to be spending $50 to $60 every 3 weeks on a tub of stuff that may not necessarily work as well. So I deal with that at a micro level with my patients in front of me. I do think that we need to have a more honest conversation with the government who struggle with that because, you know, it's a little bit like taking on the food industry and the challenges around that. I think there would be a really good opportunity with the Academy to lead some work in that space, which is, I think it's just all that look. Sign me up. Great, okay.
Join me in one final round of applause for Professor Stephen Nicholls.